First step, we did traction of the eye from the cornea using 6-0. The second step is undermining of the conjunctiva. Undermining, that is to release conjunctiva from the tenon and sclera. We use tying corneal scissor and tying forceps. Posteriorly undermining to have a good space for drainage area. After that, we take a tenonectomy. Tenon appear in between the conjunctiva and the sclera. Corneal forceps. In this step, we use corneal forceps because it is a tooth instrument. Push. After we did tenonectomy, then we have to do a shaving. That is to say, to remove all debris from the sclera to become clear. And after that, we do cauterization to stop bleeding. You have to abort bleeding because bleeding is an enemy of our procedure. This is cauterization. Next step is superficial scleral flap. As you know, we have so many shapes, either rectangular or triangular or square or semicircular, as you prefer. In this case, I will do a rectangular shape using pestle, and this is crescent knife. Crescent knife to separate sclera, superficial sclera. The diameter about 4 mm times 3 mm. Horizontal 4 mm and vertical 2 mm. And the end point when you reach clear cornea, that is to say, we see a reflex of the cornea, we have to stop here. And we put a missile to prevent mitomycin C to scatter behind the cornea. Then we gas the conjunctiva up and we put mitomycin C. Mitomycin C under conjunctival flap. Mitomycin C is antifibrotic agent, concentration 0.2 to 0.4%, and you have to put it for at least 2 to 5 minutes beneath the conjunctiva. And light should be put off to prevent the eye. Mitomycin C, antifibrotic agent. We will prepare it for concentration 0.2 to 0.4, either 0.2 or 0.4% accordingly. In some cases, if you have high-risk patient like repeated trabeculectomy, black races, pediatrics of a strong tenon, we have to increase our concentration to 0.4 and to increase time to 3 to 4 or 5 minutes. In elderly, we have to decrease concentration to 0.2%, and the time should be lower, 2 minutes, like 2 minutes, because as you know, in elderly, conjunctiva is very thin, and we are afraid about the complication of mitomycin C. It may cause thinning of conjunctiva and even conjunctival rupture. So you have to put it for a low concentration and few times, 2 minutes. After that, we remove mitomycin C carefully. Our aim is not to touch the edge of the conjunctiva, because if you touch it, you may delay healing, and this affects our conjunctival bleb in future. We do a thorough wash. It is high time to wash all the remnant of mitomycin C. And that one, which is absorbed by the patient, is quite enough to do our function. Our aim is to keep our trabeculectomy patents all time. Mitomycin C, delay healing. And this is by delaying healing, we are sure that our procedure is okay. The patency of all pathway from posterior. This is paracentesis, very important step. We open anterior chamber through area, cerebrotemporal or cerebronasal, and then after that we do deep sclerotomy. We open anterior chamber using 15-degree venous caesar and corneal forceps. Venous caesar and corneal forceps. We take deep sclera. This is called ostium or window. This part consists of trabecular meshwork. After that, the iris come out, and we do peripheral iridectomy. And we test our patency by using ringer. You have to wash to see, is it open or not? Now it is okay, it is open. Iridectomy and deep sclerotomy is open. We put some missile inside, and as you see, this is our iridectomy area. This is the superficial scleral flap, and that is our ostium deep sclerotomy. Now we come to close. You have to close our superficial scleral flap, rectangular, 2 corners suture using 10-0. It is a rectangular shape, not triangular, so we have to close just at the end, tying quiz, tying suture. You have to close 2 corners, and the other portion keep it open to enhance drainage. not good. Yes, tying, again tying. Nice. This is our facial corner, and then the second corner. Yes. Using needle holder, tying forceps to close our superficial flap. Remember that our deep sclerotomy remain patent without closure, and also PI is patent. Just we close superficial scleral flap and the conjunctiva. This suture is not too loose or neither too loose nor too tight to enhance the range of aqueous humor. And the very important step, you have to bury it. All suture here, it should be buried because nose can harm our conjunctiva and causing conjunctival hole. After that, we use our paracentesis size to test the patency. As you see, fluid come from here. This means that it is open. So this is the first function. The second function of paracentesis. First function, you have to release intraocular pressure. When you do paracentesis, IUB comes down. Second step, or second function of paracentesis side pore, is you have to test your patency of your surgery. As you know, fluid come from here. This means it is patent. Third function is to reform anterior chamber and your conjunctival blip. And fourth function is to inject intracameral antibiotic. Now I come to close our conjunctiva. I repeat myself. Inner scleral suture, not too tight, not too loose. You need to have some area for draining. But here, conjunctiva, you have to close it strongly. That is to keep it watertight, not to allow any fluid to come back or to come out, because this is a source of infection. If you didn't close it strongly, then you allow infection and some bacteria to come inside. So you have to close it. Number one, to avoid infection. Number two, to keep your conjunctiva closed to form something called conjunctival blip. Now, after that, conjunctiva turn from conjunctival flap to conjunctival blip. Blip is very important. It is a chamber outside created by our surgery to keep aqueous humor. When the tension raise, fluid come from inside to outside the chamber to form this conjunctival blip. And vice versa. When IOB come down, some fluids come back. But you have to keep this watertight. We suture conjunctiva by 3 suture, 2 in the corner, and 1 horizontally. And 1 horizontally. This is our last suture, horizontal. And also you have to bury all suture. We use also use 10-0. In the past we use 8-0, but nowadays we use 6-0, 10-0 in all steps, closing the sclera as well as the conjunctiva. And you have to bury it. Burying in this steps is important for the patient, because if you leave nose outside, it harms the patient. It causes foreign body sensation. And the second day, you are glad your surgery is okay, IOP is okay, but the patient suffering. He said to you, I have foreign body sensation. The last step, you have to form your anterior chamber using fluid through paracentesis. In the same time, you see our pelvis form. Pelvis form after you inject this fluid, scissor, and you have to cut our traction, and you have to inject intracameral antibiotic to guard against infection, phlebitis, endophthalmitis, and others. And the last step, you have to put subconjunctival dexamethasone, mild steroid to enhance urine. And this is our last view. You have to make sure that your AC is okay, deep, your PI is patent, the bleb is formed, and conjunctiva is watertight. This is the last of our surgery. Thank you.